I want to take you through a bit of an overview of things and hopefully give you a lot of practical, useful stuff for clinic, but also obviously for next year and the rest of your lives. And I presume you've got the notes, so you've got opportunity to look through those. But what I thought I'd do is go through these 10 particular topics and just give you a little bit of a taster of each of these. We'll talk about disposable fundamentals, torics, presbyopic fitting, RGPs can be simple, dealing with GPC is the most common contact lens complication that you'll see, dealing with vision and comfort for troubleshooting, and kids and contact lenses for emmetropes. You might be going, what's that about? But if you've snuck ahead and read, you know what that's about. BV and contact lenses, because I've got to sneak a bit of BV into every single one of my lectures, and remembering the retina. So this is really, the first four are about prescribing. The next ones are about managing and then brain stretching. So different things you can do with contact lenses and just to give you a bit of an overview to help your confidence ultimately. So let's look at disposable fundamentals. A couple of key points that I want to make first of all is that daily disposables aren't expensive. And if we had enough availability of powers in daily disposables, everyone should be in daily disposables. Right, we know that there's a lower risk of infection with dailies compared to reusables. We know that the comfort's likely to be better and we don't have to worry about solutions. So this is a really interesting study I want to point you to that had a look at the cost of daily disposables versus reusables when they're not worn full time. And what this study found is that for spherical lenses, for torics and for multifocals, there was this cutoff at sort of 4 to 5 days a week of wear, where if they were worn for more than that, they got more expensive. But if they are worn for less than that, they actually were more cost effective than reusable lenses. Once you take into account that you've got to have solutions and you're going to waste them to a degree if you're using reusables and not wearing them all the time. So the key point here is that daily disposables become more expensive at 4 to 5 days a week of wear. And of course we don't want to pick a lens based on cost, we want to pick a lens on what's best for the patient. But this is hopefully a little pearl that you can use to talk to patients about next year. Though. These are expensive? No, they're not. If you're wearing them less than 4 or 5 times a week, they're the same or actually a bit more cost effective. And they're healthier and they're easier, so everything's going for them in that respect. I also just want to put a little pearl in there that hydrogels aren't evil. So silicone hydrogels came about just as I was, a bit before I graduated from university. And we need to use hydrogels sometimes. We've only recently had some silicone hydrogel daily disposables become available. So all of our daily disposables to a degree were hydrogel. We'll talk a little bit later about GPC or CLPC and how quite often you might need to change the modulus on a lens. And so a hydrogel is a much softer lens generally than a silicone hydrogel is. Sometimes we need to use hydrogels because they're outside of, powers are outside of range. And we'll talk a little bit more in the next section about torics, about this amazing availability of prescriptions we can correct with disposable contact lenses now that I had to use conventional soft lenses for. I don't even think you guys will need to fit conventional soft lenses because of the dailies that we have available, the disposables we have available. And I just wanted to introduce you, I'm sure you've been introduced before to the concept of oxygen flux. When we have a look at decay, decay is not a linear scale. So this lens here isn't half as transmissible to oxygen as this lens is here. And when we actually have a look at how much oxygen is getting through to the cornea compared to an open eye state, once we get to these silicone hydrogels and these higher decays on T, it's sort of diminishing returns. So a decay on T of 80 sees 97% oxygen get through to the cornea compared to an open eye state, and a decay of T of 160 sees 98%. So the 160 isn't twice as good as the 80. And so when we're having a look at the hydrogels, this should give you some comfort that if we're fitting a DKNT of 50, then it's actually only a little bit less than these ones. If we're fitting a DKNT of 20 and you might go, oh, that cornea is going to die. It's not going to die because it's getting a little bit less oxygen, but it's not half as much as what the other one is. So don't be too worried about that. Corneas can be sippers or gulpers of oxygen, and if they're a sipper, they might be fine in a hydrogel or a silicone hydrogel. If they're a gulper of oxygen, they might need the silicone hydrogel. Now, lens availability is something that's, we used to have guides where everything was all together. Probably the best spot where everything's all together at this point is iTalk, which is readily available if you're in independent optometry. If you're not in independent optometry, then there's probably lens ranges or availabilities that you might be more likely to use because that might be a commercial arrangement. You can always get this information from reps and fitting guides, and there's some things under development that will help to sort of get all this information together. The fitting guides I wanted to point out to you, because these are two different multifocal fitting guides for J&J lenses and for Alcon lenses. And the fitting guides have real research behind them. So multifocals can be a little bit tricky to fit, particularly when you're clearly not presbyopic yourself and the patient knows that, and you know they know that it's hard for you to understand what this is like, but you know how to fit them. And a lot of research has gone into these to make it streamlined, such that if you pick your first lens, if you have problems with distance vision, you do this. If you have problems with near vision, you do this. So a lot of that information is put together, and you can always contact reps and go to conferences and get all of this information. What makes it easier for you over time, though, is you get a bit of an idea of the lenses you're using and the parameters in your head, and that makes it easier for you to have swift discussions with patients. So let's move on to torics. And torics shouldn't be hard, but they can be a little bit hard and complex, mainly because firstly, you might not be sure what's available. So some general principles of torics, which you might have figured out for yourself already, is that most cil axes are in 10-degree steps. Most cil powers come in these here. So pretty much all the torics come in those steps. So don't go ordering a 1D cell, because the lab will go, what do you want? Do you want a 125 or a 075? You got to pick. Check availabilities for 225 cil or more, because they're not all readily available. And there's less cil axis availability in daily disposables. So if you've got an Axis 50, for example, that's going to be fine in a monthly lens, but it might not be fine in a daily disposable. Measuring rotation is very important, because that helps you figure out how the lens is behaving. And something I wanted to point out is that it's important to measure rotation from the edge of the marker to the pupil center. This is a little bit hard to see here. I'm not sure if you can see that the toric marker here is actually going straight up here. But if the toric marker, a straight line was joined between the toric marker, or if that straight line was continued, it wouldn't go through the center of the pupil. So there's no point lining up a beam along the line of that toric marker. If it's not going through the center of the pupil, you're not measuring rotation, you're measuring some chord of something. So line up the edge of the toric marker with the center of the pupil. You should have a little graticule on your slit lamp to spin around. And it's really important that you do note, didn't mean to press that. Do note the rotation, and you remember that it's meant to be rotated there for next time. So if you've adjusted for 10 degrees of rotation, and then you come back and go, oh, it's rotated 10 degrees, and then you adjust again, you'll just keep chasing a cil axis around the clock. So make sure you note that it was 10 degrees rotated, you've adjusted that, so you expect it to be 10 degrees rotated next time. The other thing that I want to chat to you about briefly is stable versus unstable rotation. So if a patient has been fit with a toric lens and their vision is consistently dodgy, that's actually easier for you to fix than if their vision is on and off and on and off. Because if we've got a lens that has unstable rotation, then it might mean that that lens is just not suitable for that patient. Whereas if we've got a lens that is stably rotated, so it's giving them consistently dodgy vision, well, you can adjust for that. So that's something I actually talk to my toric patients about and say, if it's on and off and on and off, it might not be the right lens for you. But if it is a bit off and it's there all the time, then it's probably something that I can quite easily fix. The other thing that's important is to take repeated measures. So don't just look once. Get the patient to look around, have some blinks and measure again, have some big squeezy blinks and measure again, because you only ever get that maybe 10, 15 minute sample of what's happening with that lens in the patient's life. And doing the repeated measures can give you an idea about whether you've got a stable lens or whether perhaps it is unstable. And if it's unstable, you could fix for average rotation if it's only a little bit of instability, but if it's going between 10 degrees temporal and 10 degrees nasal, what are you going to order? You can't give the patient a different lens for different times of day. That lens isn't stable, go for a different one. Now I just wanted to save you some time with over-refractions on toric lenses as well. So if a toric lens is rotated, you're going to get an over-ret result of plus with a minus cil, and generally it's going to be on an oblique-ish axis. So if you're doing an over-ret on a toric lens and the cil axis that you're seeing in your ret reflex doesn't match the cil axis of the contact lens, so if we've got a cil axis of 180 degrees and we're seeing something like this, come on in, grab some food if you want. Then in a toric lens, that indicates rotation of the lens. And you can spend ages trying to ret that and over-refract, and there's calculations you can do to work out how much rotation that is. Too complicated. If you're seeing that the cil axis is not lining up with the actual cil axis of the contact lens, abandon ship, this is rotation. So jump on the slit lamp and measure how much rotation there is, and just don't worry too much more about your over-ret. However, if your sill axis matches the actual sill axis of the contact lens, so if you're getting plus 025 with a minus 050 sill by 180, and that prescription axis is 180, then don't abandon ship, put effort into that one and measure it. So if your over-ret shows toricity which matches the axis of the contact lens, then you can measure it. Now, if you've got a spherical lens, you can trust whatever you're measuring over the top, but a rotated toric lens just creates so much distortion and refractive watts-are that you don't need to spend a bunch of time measuring this. If you see that plus with a minus sill, go, all right, put my ret down, because you should all be picking up your ret first, obviously. Hopefully I've all indoctrinated you with new love of your ret. If you're seeing that, abandon ship, pop it down and measure the rotation. If you've got it aligning with the axis of the contact lens, then go for it, then measure that properly. And for high astigmatism, as I said earlier, I don't know if you guys will ever need to order a conventional soft lens because of our availability for disposables. And we've got these disposable monthlies available now, which is just fantastic. We can go up to 575 sil with the Pro Clear and the Biofinity XR Toric from Cooper Vision. The Frequency XL XR Toric, that's a hydrogel, and this is a hydrogel as well. This is a really comfortable, very stable lens. They all are. This one here is a newer one, and you can get 5-degree steps in these. So that really covers loads of prescriptions, and there's very high amounts of plus and minus. Some of these are available plus 20 to minus 20 as well. So have a look at availability for that, but keep that one up your sleeve for the patient who has these levels of sil that are outside the range of their of your standard 075 to 175 availabilities. And the J&J Oasis Toric comes in a 275 sil now and some powers, so I just want to point that out to you as well, because that's great, having a fortnightly lens. Obviously, for some people, replacing a lens twice as often in a fortnightly compared to a monthly can be desirable, and it's really quickly available. These guys are semi-custom made over in England, and I like to joke that they come over by carrier pigeon, so they take about 3 or 4 weeks. There's probably no pigeons involved, it's probably very sanitary, but they take a while. So a 275 sil you might want to go for something like this. We've got these things available. It just makes me die a little inside when I have a patient come who said, the last optometrist said I can't wear contacts because of astigmatism. Oh, look at all of these things that are available. There's so many things that we can try. And these people do really well in contacts. So that's torics. Let's talk about presbyopes, the other group that's probably a little bit more terrifying. Now, what I want to highlight first of all is what we're doing with presbyopes, and unfortunately what we're doing is not enough. So once we get to our presbyopic age group, 100% of people need a correction, right? So 100% of people of this age group coming through your door could be suitable for contact lenses. However, in Australia, only 41% of our presbyopes are actually fit with presbyopic corrections. What that means is 59% of them are being fit with single vision distance and putting glasses over the top. And that's a little bit shocking when I read that. I thought, hang on, I'm trying hard with monovision and multifocals and all of this sort of stuff, but that's actually not what's happening out there. So in Portugal, these guys are awesome, and they're fitting 80% of their presbyopes with presbyopic corrections, most of them being multifocal. Down here in Singapore, no one's getting presbyopic corrections. Who's better than us? Hong Kong, Canada, I think that's Belgium, I think that's Colombia, that's like Estonia or something. Anyway, they're all doing better than us. So we can improve this, and this data's a little bit old now. We're sort of awaiting some newer data, but this indicates a lot of presbyopes aren't getting what they need visually, and so what incentive do they have to continue with contacts? Maybe they're only wearing them part-time and just for distance. The other thing that's a little bit shocking as well is that multifocals fit to presbyopes is quite equivalent, or only a little bit more, than RGPs fit to presbyopes. And you might think, whoa, I won't be doing loads of those next year. Well, I would love for you guys to go out there and fit a lot more multifocals to presbyopes, to give them the vision they need, give them their best crack at having good vision. And over the past couple of years, we've had heaps more daily disposable multifocals become available. So there's lots more options for these patients who might have a little bit more dry eye. There's heaps of toys for you to play with now. Now, we've got, these are just sort of the big 4 guys, just to give you a little bit of an idea of availability. We've got distance-centered multifocals. Obviously, we're interested in these for myopia control, which we talked about a few weeks ago. These can also be really useful for the early presbyopic myope who's very fussy about their distance vision. I'm allowed to say that because I'm a myope. I'm not an early presbyope yet. It will happen to me in the near future. But they can be very useful in that sort of situation. But these lenses which are available from Cooper Vision, their fitting guide actually says once you get to a 1752 ad, you need a distance eye and a reading eye, or 2 reading eyes. So you can't go 2 distance eyes forever, distance-centered lenses, sorry. It won't correct near enough. So most of the lenses available are centre near. Centre near makes sense because your pupil constricts when you read. That's how I explain it to patients. So you zoom in more on the reading part of the lens, and then when you look long distance, your pupil gets a bit bigger, then you've got more of the other part of the lens. I explain these to patients like looking through a screen door. So if you're looking through a screen door, you can choose to look at the screen, so that's the reading portion, which is they're close focus, they're aware of what's happening outside, but they're focusing here. Or they can choose to look outside the screen and they'll be aware the screen is in the way. It's not as clear as if they're looking through a glass window, so that's their single vision distance, but they learn to ignore that because they're focusing on the outside world. And that can help patients to understand that it's not meant to be perfect. Preparing expectations is really important with multifocal contact lenses. So we've got all of these daily disposables available that we didn't have available a few years ago. You guys have got it so good now. Back in my day, we didn't have these. And we've got silicone hydrogel lenses as well, and some of them available in one daily disposable too. So multifocals versus monovision, I think it should be a fairly simple choice really, that if we've got an ad higher than 150, that you really should go for multifocals. And this is especially for our patients who are doing a lot of computer work, because what's the far point of a 150 ad? It's about 67 centimetres, right? It's the distance we read at. And a computer is normally going to be at that sort of distance. So if you give someone a single vision near pair of glasses and they've got a 175 ad, that's not going to be good for the screen. They're going to need an extended focus spectacle lens. So in the same way, these people need an extended focus contact lens once their ads get higher. And if you were doing monovision, same deal. It's going to be outside the range of that monovision eye if the ad is higher than that. So if the ad's higher than that, it just makes utter sense that you go for multifocals. And even in people with lower ads, research has shown that people generally prefer multifocals more, even if they might get slightly sharper acuity with monovision. It's easier to tolerate. Now we have to do monovision though for astigmats, don't we? Because we've got one toric multifocal I'll get to in a tick, but for the most part, we don't have much availability there. So with an astigmat, we've pretty much got to go for monovision straight off the bat. Or distance with near over the top. However, have you heard of the ProClear multifocal toric? So that one comes from England as well by carrier pigeon. The thing that will just mess with your head is that the toric markers are along the horizontal and not at the bottom. Has anyone been burnt by this yet? Yeah, you go, I can't quite conceptualize the rotation. I've got to sort of turn my head to figure it out. But you're going, whoa, this lens is so far off, and it's actually marked along the horizontal. But there's huge availability, huge amounts of ads, distance and near centers. This might be something we use a bit more for myopia control for our myopic astigmats, but we do have that. They just take a little bit to arrive. Now, I just wanted to talk a little bit about monocular acuity measurement. Let's go back to our simple spherical multifocal lens wearer. And this is a patient, a case, name has been changed, who is an emmetropic presbyope. And she really hates her glasses and she really is motivated to wear contact lenses. So her prescription's pretty simple, the sort of thing we'd expect to see. I started with a plus 025 medium and I've just dropped that plus down a bit because emmetropic presbyopes don't like a lot of plus at distance. Now, when she, on the initial fitting and also when she came back, we found that the right eye was working a bit better than the left eye. And you might go, hang on, she's the same prescription in each eye, it's the same contact lens, why the difference? And that's because different eyes can work differently. So just because someone's got exactly the same script in each eye and you're putting the same lens on each eye doesn't mean the eyes will work exactly the same, because there's the inherent optics of a person's eyeball that's got to work with the optics of the contact lens. And just the same as everyone's got different sensitivities to blur. So you might have a minus 050 who says, I'm blind and I'm 6'12", and then you might have a minus 050 who's 6'6" and isn't bothered. In the same way, there can be some variation between eyes. So measuring monocular acuity can help you figure out what's going on. Okay, we've got good reading vision, We could probably afford to lose a bit of this because we're N4 minus in this eye, but we've lost a bit of distance. So it's very, very easy for you to figure out what you're going to do to improve that binocularly. Now, I also just wanted to introduce you to the case of John, who is a mad keen cyclist. He's got a decent amount of sil there, so we've ordered ProClear multifocal torics for him, and he's got a distance-centered lens in this eye and a near-centered lens in this eye. So when we have a look at the monocular acuity, you might expect the distance-centered lens is going to have not as good near vision, but look, it's actually similar to this. And the near-centered lens, you'd expect, okay, that might be a little bit dicey for distance. But in fact, if this one isn't better for near, then it's likely due to, in this case, it was due to lens rotation. So you might measure his acuity binocularly and he might say, oh, I'm having some problems with my distance vision. And you might think, oh, it's this lens, because that's a distance-centered lens. But actually, when you have a look at them monocularly, it's lens rotation of the left eye was the issue here. So what do you do for the amblyop? I like this little cartoon, poor little guy. So I've had a couple of patients who are conveniently alternating exotropes and using a different eye to distance to near, and they can wear monovision. There's no reason why they can't. They probably can't wear multifocals because they're not using their eyes ever at the same time, but keep that in mind, it can work. And if someone's a mild amblyop up to 612, they might be fine with multifocals, or depending on what their particular higher visual demand is. If they're a bit more fussy about their distance vision, maybe you optimize that in their good eye. If they're a bit fussier about their reading vision, maybe you optimize that in their good eye. But they can still wear them, you might just have to do a little bit of a modified setup. Same with someone who's toric in one eye. So you might fit a toric single vision distance in one lens and then a multifocal in the other eye. So you've got those options, and just because someone's an amblyop doesn't mean they can't have a proper presbyopic contact lens correction. Just have a look at how they're using their eyes. And that's super easy, obviously, to figure out with cover test. Now, when you're managing expectations, it's important right from the outset to say that 70 to 80% of people adapt to these lenses well. It's probably a little bit higher for multifocals, so that gives them the impetus to be part of the majority. And that these contact lenses will be about 80 to 90% as good as your glasses. They're not going to be 100%, because nothing's as good as using 2 eyes for distance and 2 eyes for reading like in your multifocals, but it's going to be 80 to 90% as good, and whatever's left over, you're happy to tolerate that because at least you don't have to wear glasses anymore. Or some people sometimes want top-up glasses to give them a bit more plus at near, or they might want top-up glasses for a bit more minus at distance. That's important as well. I was at a conference last year and I walked up to a friend of mine who's in his early 60s. He's wearing multifocals, he's just a full-on living and breathing contact lens practitioner. And he had a pair of glasses on and was looking at his phone. And I said, what's with these glasses? Aren't you wearing multifocals? And I know that when I first started all of this contact lens work, I would feel guilty if I had glasses on, and patients would go, what's with your glasses? Why aren't you wearing contact lenses? Anyway, you do what you want as practitioners. You don't have to be pressured by your patients. But I said to him, practitioner, what's with these glasses? And he said, no, seriously, trust me, when you're 60 years old, you want that extra plus. And he said, don't be shy with it, give people that extra plus. So even if they're full out in their multifocals, they might like 150 or 2 over the top to dial it up. So don't think you've failed if you need top-up glasses, because there is a bit of their life where these contacts aren't going to be as good as what glasses are. Keep that in mind as an option. So pick a lens based on material and modality first. Obviously, if someone's an astigmat, that narrows your options a little bit, but it gives you an idea about where you start the discussion. You might pick a material first of all because you've got a dry eye patient, you want a daily disposable. You might give them a couple different daily disposables to try, which I'll mention in a moment, I do quite often. If you're not getting good acuity, try a different lens design. And I describe these lens designs to patients like different types of sneakers, and anyone who's sat in with me has heard all my sneaker analogies over the past couple of weeks. You'll hear them tomorrow. So if you've got, the way I describe that is if you imagine that you've got your size is like your prescription. If I line up a bunch of sneakers in your size and I say, which do you like the best? You don't know because you've got to try them. And it might be that one style of sneaker doesn't work for you regardless of the size, so regardless of us changing the prescription, because it's too wide or narrow or whatever. So we've got to find the sneaker that suits you. And so if I give you a couple different types to try, then you'll be able to see which is better in terms of vision and comfort. It's difficult for patients to understand, and they might expect that a lens is a lens is a lens. Same with progressive lenses. This is a useful analogy for progressive spectacle lenses as well, that they're not all created equal. So a different lens design in exactly the same power could give you a very different result for that patient. I quite often give patients 2 types of daily disposable multifocal and ask them to wear them for at least a few days before making a call and before changing to the next one, because that way they get to compare vision and comfort. With low sills, you may not need to correct the 0.75 in one person, you might really need to correct the 0.75 in another person. So it's easy for you to see if it's visually significant in a trial frame. If you gave them a monovision correction, for example, and then you could see what it's like without the sill and what it's like with the sill. One person with 0.75 sills might desperately need it for near and not for distance at all. And that might mean that you fit a toric in one eye and a multifocal in the other. But everyone responds to their sills differently, like everyone responds to multifocal lenses differently. For high sills, remember you've got the ProClear Toric multifocal, or you can go for monovision. But you do have that multifocal option. It just takes a little bit longer to go through the process because they take a while to come in. So RGPs can be made simple. We've gone from torics, we've gone to presbyopes. Okay, let's reach the RGP summit. So I put a fairly complex table that you've got in your notes there, and this is something I've done for my colleague optoms to help them. And ultimately, a bit chopped off at the top, ultimately it doesn't have to be too hard when you're fitting RGPs. Your first question is the corneal sill less than 150 or more than 150? Sorry, that's exactly the same, but that's meant to be more than 150. So if it's less than 150, you're probably going to pick a spherical lens. I've put some lenses in here which are Capricornia contact lenses. That's a local lab and we use them most of the time. So these are just sort of standard shaped contact lenses for standard shaped eyeballs, and bigger diameters are generally better. Just pick the flat K, that's where you can start from, and then you go from there, you assess your fit, and you guys all know how to do that. Whereas if you've got a corneal sill more than 150, don't do a trial fit because you need a toric lens. And the toric lens is actually going to sit on the eye once you've got more than 150 of sill. If you've got less than that, it won't actually lock in hand in glove. So just talk to the lab, tell them the Ks, tell them the Rx, tell them that you want a lens and the diameter you want, and the job's done. And you order those lenses with a per case warranty so that you've got opportunities to alter it if need be. With your trial fit for the lower amount of corneal sill, you do your over-refraction, you add that together to get your final prescription, and then you determine the fit. And think about what's happening at the center and the edge of the lens. With a soft lens, you basically work out, is it tight or loose or fine? So with movement, is it too much or not enough or fine? And anything in between too much and not enough is fine. I know that sounds very unscientific, but millimeters of stuff isn't necessarily what's going to help you figure out if something's comfortable in a patient's eye or not. With a rigid lens though, we need to think, have we got clearance in the center, too much or not enough, and what's happening at the edge. And you can talk to the lab about saying, I like the center, but I need a tighter edge. There's just that extra step to do. With your toric lens for the patient with corneal toricity, you send the lab the steep and flat Ks and the ocular refraction. So you've corrected for effectivity, you get a lens, and then you go from there. That's like your first trial lens, except the patient pays for it, and then you have your warranties to adjust it. If you've got keratoconus or an irregular cornea, then you use topography. So I've put some notes in here about KBA, Epicon and CAT lenses, which are all Capricornia lenses. You can have a look at the Capricornia website to find out more. You might have been exposed to these in clinic. Have you had a play with any of these lenses? I'm pretty sure there's trial sets there. So these have different, you can either use topography to predict them. They have guides in their trial kit. There's more training you can do with these. I'm not going to teach you how to fit these right now because we don't have enough time. But it's just to give you an idea that even in this case, you just do your over-refraction to get the final script, and then you determine the fit. You think about the center and the periphery. What do you need to do in the center? What do you need to do in the periphery? With these mini scleral lenses, you might be using OCT. So there's more information there, but ultimately you can see that it all gets pretty simple here once we've just picked a lens and put it on eye or ordered a lens to start with more corneal toricity. Make sure you include in the order the material of the lens, the colors. That's engraved right and left, so you might want the lens engraved more so you can see it. The patient probably can't see it if they've got this much ametropia. You can have them different colours, so quite often I'll have the right one purple and the left eye blue. Purple's got an R in it, blue's got an L in it, so that the patient can see the difference between them in the case. And then any changes you might need to the lens edge or periphery. And then when you follow them up, you're wanting to check their vision, the over-refraction, fit, movement. You're having a look at all of this stuff to do with eye health, and you're also having a look at the stuff to do with fit. And again, think about the centre and the periphery of the lens. So that's a whole bunch of RGP fitting, just boiled down to hopefully what you'll find a bit of a simple reference, that you don't go mucking around with a trial fit for an hour when you've got a bunch of corneal sill. Just order a lens and go from there. If you've got a low amount of corneal sill, that's when you do your trial fit. And this sort of stuff, you're generally going to get support from when you're fitting this. If you're going into a practice where a lot of this is done, then you're going to get support in learning to do that. You won't have to hopefully do that all by yourself the first time. So I just want to talk to you about a case of an RGP diagnostic fitting. And I don't know if you guys get any trial lens sets from labs in your final year. Do you get actual trial lens sets for yourself? Might not be offered anymore because there's lots more of you now. But this, wherever you are, if it doesn't have a trial lens set, you can buy one. You can just call a lab and ask for a TLT set or a ModCon set. And these are just basically, those words TLT and ModCon are just a way of describing the design of the lens, the shape of it, without having to write out all of those numbers, as you probably remember from lens design. So having an RGP set just to do a diagnostic fit can help you figure stuff out. And this was a case of a patient who presented with a 3 or 4 year history of his left vision being reduced. Now, you can see he's got a decent amount of fraction, and you see that. You might go, oh, is this a bit of an irregular sill? Has he got some amblyopia? You know, various things. Is something wrong at the back of his eye? But it was only a 3 or 4 year history, so if it was amblyopia, it would be longer than that. Needless to say, I went through everything we possibly could, and everything looked fine. So there was no real reason for this 675 acuity. So the last thing to do is see, is this anything to do with the surface of the eye? And I'll show you his topography in a tick, which isn't particularly obvious. But we did a diagnostic RGP fit, just picked his flat K, popped the lens on, and we actually got, so even though we've got this much sill, and you might go, hang on, that's a lot of sill, you're counteracting what you just said before, Kate, but I haven't showed you the corneal sill yet. So his over-refraction, minus 150-ish, that's not such a big deal. What I want to point out to you is how much that acuity improved with the RGP. So that immediately tells us there's some sort of corneal discontinuity, whatever it is, that's reducing his acuity, and it stops you freaking out about his macular or amblyopia or brain tumour or whatever. Here's the interesting thing about this guy. If you have a look at those topography maps, they're tangential maps. It doesn't look like anything's obviously bad going on here. Sure, there's a little bit of irregularity through there. But there's a big mismatch between his corneal and spec sill, and there isn't so much on this eye. And so there's something a little bit unusual refractively about that cornea. And I'm not going to diagnose it for you any better than something a little bit unusual, but whatever it was, it resolved with an RGP fitting. So I actually fit him with RGPs, and we did a distance eye and a reading eye, and he got amazing acuity, and we've corrected that problem. So over time, this guy's gone back into glasses again, and he's still got that slight limitation of his acuity because he just got a bit lazy with his RGPs. But I probably would have chased my tail around and around trying to figure out what was wrong with that 675 eye, and just whacking an RGP on was super quick and gave me a good idea straight away that something was going on with that topography. Have you encountered Progent before? Yeah, it's pretty magical stuff. So it's a really important thing for any rigid lens wearer to use on a regular basis. It's actually fine, Menacon say it's fine to use with rigid lenses every 2 weeks. So lenses won't get dissolved away if it's used more often. But as lenses get older, it's a really important tool to make sure that the patient has the best vision they can, the best comfort they can, and that their eyes are healthy and the lenses last as well. So if you haven't learnt anything about Progent yet, ask someone who has, but it's just an A and a B capsule that go into the case for half an hour, job done, pretty magic stuff. Okay, so now you're all feeling confident with RGPs, you're ready to go out and fit them. No, I know, that's okay, it was only a couple of minutes. But hopefully it's a bit clearer in your head. That's the whole thing, is just thinking logically. It helps with everything in practice. So I wanted to put a special section in about GPC because it's the most common complication you're going to see. It's probably about 5% of contact lens wearers in research has shown that tend to have GPC, and kids and adults similar rate of GPC, not always necessarily associated with allergies, seasonal allergies. That's maybe a little bit out of focus, but hopefully you can see some nice dots there. And the way I describe this to patients or to you guys is that it's generally caused by mechanical or chemical irritation. So mechanical is having the lens on eye, the modulus of the lens. Chemical is the solution or build up on the lens. So you've got a variety of different treatments. You can go from ceasing wear right to actually just changing solutions. Because if you've got a keratoconic, for example, you can't get them to cease wear. What are they going to do? They're going to sit home and cry for 2 weeks while their GPC gets better. You're going to have to just change their solution. You can't reduce wearing time necessarily, can't reduce modulus, change their solutions and look at your therapeutic treatments. Whereas if you've got someone, a -2, who's just abusing their silicone hydrogels and leaving them in, doing extended wear, then that's when you've got all of these options available to you, but sometimes you don't. Xadatin works quite well, but I'll show you a case in a tick of someone who just needed a bigger gun. So if it's pretty decent, don't be afraid to prescribe FML. That's the first thing that I prescribed when I got my therapeutics endorsement 11 years ago now, was FML. Don't be afraid of steroids because they're amazing things, particularly for just knocking this stuff on the head rather than letting it grumble on. And I'll show you a case in a tick. So this is an interesting case where you can see that there's a nice little knobbly GPC here. And down here you can see that this contact lens is sitting stupidly on the eye. So the patient's looked up and it's been pulled up a mile. So the question is, so with this patient, they were doing extended wear. They refused to be persuaded out of extended wear. And so they were changed to a 2-weekly lens rather than a monthly lens to try and improve comfort and smeariness and eye health. So this patient came back after a week and said that they'd had extreme irritation and unstable vision in the right eye, but the left eye was fine. And when we had a look at the fit of the right eye, it's awful like this, and we've got this little knobbly guy underneath the eyelid. So we've got focal GPC, the contact lens is sitting high and temporally, so of course he's wearing a toric, of course he's going to have unstable vision. Even with a sphere he'd have unstable vision. The left one is completely fine. So the question is, what came first? Was the lens a bad fit and that caused the GPC? Or was the GPC already starting to form and that made the lens fit badly, and then that's just a vicious cycle? Regardless, we need to cease lens wear. This patient can afford to do that because he's just a soft lens wearer. Cease lens wear, go for Xadatin or FML, and then go from there, and then work out, can we still use this lens or do we need to change to a different lens type? It's not often with the modern lenses that we have available that they fit awfully like that. It's just not often that lenses don't fit. They really are one size fits most with these disposables. But this was an interesting one in sort of being unsure which came first out of the two. Doesn't really change your management though. So this is a patient who had a grumbling GPC for quite a while. He was fit with a Pure Vision Toric. That's a fairly high modulus lens, and there's Pure Vision 2 Toric available now, so this case is a few years old. So after 18 months, he developed GPC in one eye, not the other. And that happens pretty often as well. I don't know why it's one eye. Why does your throat get sore in one eye, one side when you get sick? Who knows? It can just happen in one eye, not the other. So firstly, we went for Patanol. This was before unit dose Xadatin was available. I love unit dose Xadatin because it's preservative free. It doesn't have BAK in it like Patanol does. So it's generally my go-to for allergies. But 6 months later, it returned again. So it resolved, stayed in those lenses. 6 months later, it came back. So we went, okay, we have to work harder. We have to do everything now. So let's cease lens wear for 3 weeks. Let's change solution, and let's change to a lower modulus lens, which is a hydrogel. But he's not doing extended wear, so that's fine. So that worked for a month, and then it came back. And we tried again to use Patanol, and he just didn't respond. So you just got to pull out the bigger gun. And in this case, if I had this case over today, I'd probably go straight to FML. Being that big and chunky and ropey, just better to hit it hard and fast than to let it grumble on. So he went to FML, he needed that for a month, and then he used Patanol for another 2 months as prophylaxis. And he's been in the ProClear Toric for many years now without a recurrence. So my lesson to you is just go hard and fast at it, and don't be afraid to shoot with the bigger gun. Go straight for something like FML. But you can see how we did everything and we still had a bit of an issue there. So, vision and comfort. I wanted to bring this up because this helps. What I really want to do with these lectures is try and simplify things for you, simplify your clinical thinking. Because when you graduate, you have so much stuff in your head and it's all equally important, and it's hard for you to sift through and sort of work out what the key things are. So I want to try and give you little rules of thumb and cheat sheets and things like that to try and make your clinical thinking simple. So when it comes to troubleshooting contact lens problems, I want you to think about vision or comfort problems. These things are related, which we'll go on about in a tick, but you can have vision problems, refraction, instability, that sort of thing. You can have comfort problems, and when I get the patient back, I always want to know how's your vision and how's your comfort. So you're getting an idea of how well the lenses are working. These are for us to work out how successful the patient is, but also to troubleshoot. But vision and comfort are related. So here's our case of the GPC patient. He comes in saying his vision's really bad. He might not be bothered by the lens, but it's actually not a vision thing, is it? It's an eye health thing. It's more of a comfort thing. Somebody with significant dry eye is going to possibly complain a bit more about their comfort, but they might say their vision's patchy and coming and going, and that might be because the contact lens is going foggy. That's a contact lens going foggy. It might be a bit hard to see. So if somebody's not appropriately managing their dry eye, it doesn't matter what contact lens you pick, it's going to look smeary. And also quite often binocular vision problems might manifest as someone saying their contact lenses are dry. Because when you're working harder to see something, you stare more and your tears evaporate more readily. So we might think things are refractive when in fact they're more to do with dry eye, and vice versa. But think about vision and comfort as giving you a clear direction as the two things you need to sort out for your patients when you're fitting them with contact lenses, and for troubleshooting any dissatisfaction with them. Kids and contact lenses. We've talked a little bit about this, obviously, well, a lot about this when it comes to myopia control, but I'm going to give you some other reasons to fit kids with contact lenses. The first is anisometropia, and there's a percentage of the population who have more than 2 diopters of anisometropia, and they'll generally feel better in a contact lens correction than in spectacles. Strabismus, you might find that you get a full-time visual stimulus with contact lens correction, particularly with decent amounts of plus. If kids aren't compliant with their glasses, then it can be a good option. For amblyopia, particularly if it's associated with anisometropia, 22% of kids don't actually need any patching, they just need full correction, and they'll improve and improve and improve. And if you've got a plano eye and a +4 eye, contact lenses might be the only way to make that happen. Children under 7 are more responsive to amblyopia treatment, obviously, you know that. That's not something that's unusual, but here's a mouthful. Anisometropic amblyopia without strabismus can respond to treatment in older children and adults beyond that typical critical period. So if you've got a kid who's come to you with reduced acuity and they're +1 and +4 and they're 12, there's no strabismus, you could actually improve that amblyopia, and the contact lens correction improves compliance and wearing time. Another really important reason to fit kids with contact lenses is appearance, and we're lucky that glasses are heaps cooler nowadays than what they were in the past, or if anyone had glasses as a kid, maybe it wasn't so cool as it is now, but there's still a lot of kids who don't want to wear their glasses because some kid made a comment or whatever the case is. So unfortunately, a great percentage of kids experience bullying, and spectacle wearers are more likely to be a victim of bullying. And I think this is still post Harry Potter. So, you know, Harry Potter's done a lot for kids wanting to wear specs, but it's not cured all of our ills. And I've mentioned this research before, that fitting children with contact lenses improves their self-perception. It makes them think that they're actually more athletically competent and also more scholastically competent. They're more satisfied with their correction. It's interesting, there's another piece of, I think it was in this research actually, that these researchers found that kids who are wearing glasses, kids who look at other kids wearing glasses, think that the kids wearing glasses are smarter and more honest, and they want to work with them in group work projects. But those kids themselves wearing glasses aren't as happy with things and think that they're smarter and more capable if they're wearing contact lenses. So there's psychological benefits to contact lens wear. And it's important to sort of feel out if the kid's keen and the parent isn't, to be able to reassure the parent and have a conversation about that. Myopia Control, gee, I've told you guys a lot about that, but obviously contact lens fitting for kids is the real runs on the board for Myopia Control are in the contact lens arena. So if you're going to do myopia management, you need to be confident and competent with pediatric contact lens fitting. That doesn't necessarily have to just be ortho-K because we've got more and more options available to us in the soft lens arena, and the real future of widespread myopia control is going to be in soft lenses because they're so accessible. Now, these sorts of kids are the ones who would be good candidates for contact lens wear. So if we've got the kid who's plus 350, particularly if we've got some amblyopia or a bit of a strab and they're not wearing their glasses, then they're a good candidate for contact lenses. The active myope or the anisometrope we talked about before, but I want to tell you about the amblyopia. And this was an interesting case, and because you've got the notes, I've spoilt the story, you know what's going to happen. So play along anyway, particularly if you haven't seen the notes. So this girl came in and her mum's a myope and she said her distance vision's blurred and she's 6'12", and I'm thinking, oh, this is easy. She's just -1. That's what's going on here. But in fact, my ret was right and left +4. And I went, whew, I wasn't expecting that. And her acuity didn't improve with that result. Didn't matter what I put in front of her, I couldn't get her past 6'12". Or acuity was, sorry, it was a tiny bit better, a few letters better. She had no strabismus, which is weird. Her vergence was completely normal, which is weird. You think someone would be ESO as anything, might have decompensated with an uncorrected +4. She was slow to clear +2 and -2 at near, unaided. So you think, hang on, wouldn't she love this plus? Because she's been walking around uncorrected. But in fact, her system's so tight. So imagine you've lifted up a heavy weight and you're carrying that all the time. You get lousy at being able to put the weight down. So there's no way that I can give her more than +2 right now in this initial instance because she's not going to clear it. She can't even clear +2. Her ocular health was completely normal. So what would you do with this kid? Now, you've already got a pretty good idea of what the answer is if you've snuck ahead and read the notes. But you might think, oh, well, I'm going to stick her in glasses in +2. I'm going to stick her in contact lenses with +2. I'm going to do a cycloplegic refraction. I'm going to refer because this is freaking me out. Now, a cycloplegic refraction is something that's useful, and that would help us to know what the ceiling of her refraction is, but it doesn't tell us what we're going to prescribe her now because she still can't accept more than +2. So say you get +5 in your cyclo, that's cool, that's a number, but the number that you're going to prescribe straight away that she will accept, you've already got from that information. So I actually fit her with +2 daily disposables. I said to Mum, I can't give her glasses right now because number one, what incentive does she have to put them on? Her acuity doesn't improve very much. And number two, we need full-time corrections so we can slowly increase this script. And it is easier logistically and cheaper for Mum to do this with contact lenses than with glasses. So in this case, we didn't even prescribe glasses until we went to contact lenses first until we could increase that prescription. So just a little summary of kids and contact lenses is that kids aged 8 to 12, yeah?
So how long did you wear the contact lenses before you changed the prescription again?
It's going to depend on the patient. So the sad story with this patient is she was lost to follow-up. Mum was super distressed about the fact that her vision was so blurred and she needed a lot to understand that I couldn't just fix it straight away with a pair of glasses. So Mum went off and got 1,500 different opinions and was lost to follow-up. So I would have seen her, in other cases like this, I would have seen her probably after a month to start with and seen how much it improved. Same as if you'd prescribed a pair of specs to a younger amblyopia. You want to see them back after a month or two and check you're on the right track. Other cases similar to this, without going into too much detail of the BV, I've had a girl recently who had a similar sort of story, just this 612, 615 acuity. The ret wasn't any more than about +150, +2, even on cyclo. And her vergence and her accommodation was just frozen. Nothing moved. So the whole system needed to be improved, and I just started with +1 because she could clear +1. And I put her in that. I said, I want you in full-time +1 and I want to see what happens. And a month later, her vergence had started to improve, both a convergence and divergence. Her accommodation was still really frozen. So then we started ± flippers, and then I'd slowly snuck her up. So at that point I said, I want you to wear +1 for 2 weeks, +125 for 2 weeks, +150 to 2 weeks. You get, boxes of 30 contact lenses. and then we're going to see how your acuity improves over time. So your follow-up's going to depend on a variety of things, but in that sort of situation, I'd keep them on a fairly close watch to check that you're getting what you need to. And because it's very hard for a kid like this to be compliant with something that doesn't correct their vision so much, you know what I mean, compared to, say, a myopic kid. So I would like to know what happened, but I can only just tell you the start of that, and other cases like that as I described. So kids take a little bit longer to fit in terms of handling training, but they don't take any longer in your chair unless you're doing that training. So you might think, oh, an 8-year-old terrifies me for contact lens wear, but you know, you can have sulky, bawling 13-year-olds and the 8-year-olds might be fine. So it doesn't take a lot more time, and as I mentioned before, contact lenses for kids have a benefit beyond what we even think. Kids and teens are so much more concerned about their appearance than we are. And you get less concerned about your appearance as you get older and older. So a parent won't necessarily have much concept necessarily about what an 11 or 12-year-old is going through in terms of wearing their glasses and being compliant. As I mentioned before, it's important to reinforce care and maintenance instructions with kids, kids being 8 to 12-year-olds compared to teens. I think I mentioned this in the myopia management lecture. So there was a survey done, or a study done, where they had a look at how well kids and teens could answer questions about handling at the outset, and they both did equally well. But after 3 months, things started to fall out of the littlies' heads. So make sure you reinforce that, and each time you get them back, get them to explain things. Don't lead them and say, are you doing this? Yes, yes, yes. Tell me what you're doing, and then what do you do with your case, and then what do you do in the morning, that sort of stuff, to check if there's any holes in what they've learnt. And this is a study done where they surveyed contact lens wearers after 10 years of wear, and whether they'd started wear as an adult or as a kid, there was no difference in adverse effects or outcomes. And I believe I mentioned this to you during the myopia management lecture. If not, this is an open access paper. You can get papers anyway while you've got your QT logins. But it's an open access paper just recently published about safety of soft contact lenses in children. And it actually found, really interestingly, that kids aged 8 to 12 probably have a lower risk of infection than teens and adults, because they actually listen to what we ask them to do, and they're followed up probably a little bit more closely by their parents. They're likely more compliant. So if a parent says, oh, I'm really worried about little 10-year-old Jimmy wearing contact lenses, that's a big infection risk. Well, if he's a complete grub monster, yes, that's probably the case. But in fact, as a general rule, kids are safer contact lens wearers than teens and adults are. You can read that paper to find out more. So, contact lenses for emmetropes. We're getting into the brain stretching section. So this is a patient who's got a big sort of lumpy limbal lesion, a big patch of unhappy dryness, and you can see a whole bunch of staining extending into his inferior cornea as well. So he'd had cataract surgery 3 years prior. Before that, he'd been a contact lens wearer. And just in this right eye, it was getting red, sore, irritated, very sensitive to wind and to the outside world. And after cataract surgery, he had a very minor residual prescription. So he didn't have correction in this eye, but he had a correction still in his left eye because this eye didn't have cataract yet. So he used to be a hyperope. He used to wear contact lenses all the time. He doesn't have this dryness on his left eye, but essentially we've got an exposure problem that's developed over time and become a pretty decent exposure problem. So what I said to him is we needed to bandage this eye. Now the left eye is essentially bandaged because he's wearing a contact lens. He was actually wearing a contact lens on an extended wear basis. So that left eye really never got a chance to be exposed because there was a contact lens in the way. But the right eye did. We had a bit of ectropion, we had a couple of trichiatic lashes, and just a monstrous amount of exposure. And that sort of slightly raised limbus area, it's nothing more concerning from, say a cancer concern perspective. That isn't going to immediately go away with drops. Drops are just going to be a bandage treatment. We need to actually seal that off from the outside world. So after a few months of that, can you see how there's significantly less staining on the cornea? And this is more recently. You can see that there's not even as much staining here on the limbus. Now this guy, he's in his early 70s now. He goes on and off wearing this bandage lens. So he knows now how to manage things with drops and with lubricants. He knows particular situations he's in, if he's out on his boat or if he's in the garden a lot where that eye might start to get cranky again. I don't think we'll ever make this thing completely go away, but he'll go through periods of needing the bandage lens and then not. And it's not a refractive thing, it's just a comfort thing. But when he started with the bandage lens, I really had to convince him, because I said, your eye feels lousy with the lens on and it feels lousy with the lens off. It just feels lousy. But you've got to stick with this for a few days until that, that feeling starts to improve, those symptoms start to improve. This is not quite an emmetrope, so sorry I've put it in the emmetrope section. You can see she's a fair way off an emmetrope. But she really wanted to wear contact lenses, as you would with a prescription like this. But she had this band of SPK in each eye, just stingy, burny, really irritated eyes. And she had been referred up by another optometrist to be fit with contact lenses. Now, the first thing we needed to do, well, the first thing is I saw that her glasses were a little bit strong for her. And this is before the days of Optimel, before all of the stuff we know now about MGD treatment. But I can tell you that seeing her since, she's got barely any glands there. So this is something that we could have laboured away with MGD treatment, not necessarily gotten anywhere. So I said to her, the first thing we've got to do is sort this out, because I'm not going to be able to get you to wear any monthly disposable, you know, high cell toric or a conventional or a hybrid or anything like that until we clear this up. And it was just so happened that her glasses were a little bit strong. So the plus 050 she really liked, and she wore these True Eyes as a bandage with lubricating drops behind them for a few month period to settle this down. So that's what her right eye looked 3 months after doing this. And this is that's her left eye pre and post. You can see that's a whole lot improved, and obviously her comfort improved a lot as well. And then I could fit her with proper full correction contact lenses. So this isn't necessarily your first dry eye treatment, but think about if we've got a lot of exposure and staining, that it can be an option. I might try her an Optimel now that we have it available, rather than going straight to the bandage lenses. But it can be something that can really provide a benefit to these patients. So other things that we might be fitting, other reasons whereby we might be fitting contact lenses to emmetropes in future. Yes, Nat?
Just a quick question. How do you select a banded contact lens? Is there anything in particular you look for, or you just grab any soft contact lens style?
That's a good question. So a lot of the time it might be about the prescription first of all. So if you can go for a daily disposable, then that's ideal in this situation. It's different if we've got someone with recurrent erosions. So obviously a recurrent erosions patient needs a silicone hydrogel. You might need to do extended wear to try and settle that down. But in this case, it might be looking at what refraction you need. And you can't get many Plano daily disposables, if any. There's only one that's plus 025, which is the Pro Clear. And then a lot of them start at plus 050, or maybe you give them a little bit of minus. So I think there's different things that you could choose. So, you know, we've got water gradient contact lenses from Alcon. We've got the True Eye lens, which is a you know, a very high water content lens as well. So ultimately I probably chose that because that's a lens that I find most people find very comfortable. And another type of daily disposable could have worked just as well if it was tolerated by the patient. And dailies are generally better than monthlies for these sorts of sensitive patients. So in the future, we might be prescribing daily disposables for emmetropic allergic patients for ocular allergy. I'll tell you about that in a tick. We've obviously got UV blocking benefits. There are optoms down on the Gold Coast who prescribe Plano J&J lenses to protect these surfers from developing pterygiums. And therapeutic drug delivery. We might be using contact lenses more for that in future. So this is it's an interesting little study I want to tell you about. Allergy is on the rise, as we all know. 20% of Australians have some sort of allergy, and there's a 90% association between allergic rhinitis and allergic conjunctivitis. So it's important to ask people. I ask all of my patients if they have any problems with hay fever, so I can give them allergy information. So I can tell them I'm not just a glasses person, I'm also your eyeball GP to help you with any of these discomfort problems, to help them understand we do this therapeutic work. Now, while 13% of patients report ocular allergy, this is patients in an optometry clinic, and only 11% consult an optometrist about it. So the vast majority go to their GP, or they ask their friend or relative before they ask an optometrist about their itchy eyes. So that's where it's good to have these opportunities to just talk about red eyes with people when you're asking about things like hay fever. So this was a study done a few years ago where they got 10 grass pollen sensitive patients and then they tortured them. They shoved them in this nasty box with a very high pollen count simulation. So blew all this pollen at them. They had to stick their face in the box. I don't know how these people volunteered. Maybe they were uni students and they were promised extra credit or something like that. So they graded their redness, their bulbar and limbal, palpebral hyperemia and staining. And what they did is they did it to them with their naked eyeballs and then they did it to them with daily disposables on. And this was an Alcon daily disposable. And they found that when they had the daily disposable on, there was actually reduced symptoms, both in the type of symptom and the duration. There was reduced hyperemia and staining, and the patients just generally, their eyes looked better and felt better. So in future we might find, if somebody's got streamy, allergic-y eyes, I'm not saying a contact lens is the best thing to put on them, but in future we might find, particularly if something was combined with an anti-allergy medication, that we could be using contact lenses for this, where generally we would have thought allergies are a contraindication for contact lens wear. This might actually help people in the same way that we were talking about those bandage lenses for our dry eye patients. UV blocking benefits. We've got contact lenses that are UV blocking class 1 and class 2, and the J&J ones block UV. The My Days from Cooper Vision block UV as well. And that's really important because I'm sure you've heard about how the nasal limbus gets bucket loads more UV than the temporal limbus, because the temporal limbus gets direct UV, the nasal gets direct and also reflected, internally reflected UV from the peripheral limbus. So it's 22 times stronger at the nasal limbus than temporally, and it's 8 times stronger at the nasal lens cortex in terms of cataract risk. So fitting somebody with daily disposables with UV protection if they're spending a lot of time outside or if they've got pterygiums already on the grow, is another alternative use for contact lens beyond just correcting ametropia. And this is just explaining a little bit UV exposure at the nasal limbus in contact lenses versus non-UV blocking contact lenses versus fancy pants sunglasses that sit a mile away from the face and there's lots of internal reflection behind the sunglasses. So these are a real option for our sun-loving patients. Now, therapeutic drug delivery is really interesting, and you hear a bit about it at conferences about the things they're investigating in terms of glaucoma medications, anti-allergy medications, even things like monitoring blood glucose, slow release of glaucoma medications. And the thing about a contact lens is it provides a very unique little vehicle for a patient to have something in contact with the inside of their body for a period of time. And who knows, we might have fancy augmented reality contact lenses in future that let us, Snapchat with a blink or something like that. All sorts of cool stuff. And there's work being done that's a rabbit eye for augmented reality contact lenses, and this is a blood glucose monitoring lens. And there are some lenses available that monitor intraocular pressure as well, the triggerfish lens. So I think we'll hear more about that with time, and we might end up prescribing these sorts of things to patients to sort them out, particularly if we've got an antibiotic-laden contact lens for someone who needs a bandage for a corneal wound, for example. BV and contact lenses. Okay, I got to sneak some BV in there. Now this is a tiny bit of a recap of last week. So when we change from spectacles to contact lenses and you're a high myope, your base-in prism that you get in glasses means that you'll have an exo shift when you move to contact lenses, and there's less accommodative demand when you look away from the optical center of the lens, so you have to work harder to accommodate in glasses. And the opposite's true for the hyperope. They get base out prism when they're looking at near because they're looking through, so the thicker part of the lens is out here now, base out prism, which means they have an ESO shift when they go to their contact lenses. There's more accommodative demand in the glasses, so it's easier in the contact lenses. So as I mentioned last week, we need to keep a watch for someone like the early presbyopic myope who will need an add in their contact lenses sooner than they will in their glasses. We need to think about the low myope who's previously uncorrected at near. If they're happy getting around uncorrected and then all of a sudden they have to actually accommodate, they might really struggle with that. And they might come back and say, my contacts feel dry, and you think it's a comfort thing, I've got to change a material or change solution, but in fact it might be to do with their accommodative insufficiency and they're not blinking enough because they're finding it hard to see. And risk factors for myopia progression, obviously ESO and accommodative lag. Sometimes that can get worse in contact lenses, sometimes it can get better, so you need to monitor those. With hyperopia, we talked about the early presbyopic hyperope because they might have problems accommodating in the contact lens, or it's a different accommodation experience. But also you've got the opportunity to use contact lenses, as we talked about for those kids before. So the child who wouldn't accept their full plus, that you can increase it. Same sort of thing for adults as well. So I'll just show you a case of that. So this is a patient who was 27, this was her first eye exam. She was having lots of problems with headaches and she was referred by her GP. She was a personal assistant, so she was on the computer all the time. And she said once she thought about it, she's always felt her eyes were tired at the computer and she needed regular breaks when reading. Here's her BV results. So we can see her unaided vision's fine, so she thinks she doesn't have a vision problem. She's got a decent amount of esophoria. This is her divergent fusion reserves, negative fusion reserves, and we can see we don't have anywhere near enough petrol in the tank to balance this posture. Remember, we want about twice as much petrol in the tank by Sheard's criterion to balance the posture, and it's the other way around. She can't clear minus. Her ret's showing some pretty decent plus. Imagine just dealing with this, staring at a computer all day and having that uncorrected. But subjective, she couldn't accept that. And when we have a look at her NRA over the top of her prescription, she can only accept plus 125. So we can't just go giving her a whole bunch of plus and go get on with it, because she'll just not wear it and maybe go somewhere else and get lousy glasses that do half the job. So for her, we started with just plus 150 contact lenses, and then we gave her vision training for a poor divergence. Obviously this is going to improve with plus, but we needed to try and kick that along to get her to relax, to accept more plus. And then we slowly increased it with time, and now 3 years on, she's up at her full prescription. So that had increased a little bit from there once her eyes actually started to relax from that first ret. So she actually went a couple of years before she even got a pair of glasses, because I said, I want to wait until your script's stable until we get you glasses. And we had to make sure that she would accept them. And then when she got her first pair of glasses, she said, everything looks so big, and she didn't really like them anyway. So there's a lot of patients who get so used to their contact lenses, they don't want to get glasses. That's another really important thing, is they need backup glasses. And the +8 presbyope who's wearing RGPs all the time, this is an actual patient, you know it's going to sting them. It's going to sting them financially and just for the very principle of it, to have to spend $800 on a pair of progressives. But they need to have them, even though they're hardly ever wearing them, so they have an option, so they have a backup. Even if they have that pair of glasses for 4 or 5 years, sometimes you need quite a few appointments to work on them to get them to actually invest in these glasses. But in this case, we couldn't do it until she got to a stable prescription, and that was easy to do with contact lenses. This is a patient who sort of looks a bit like this. And at the time, she was 19 years old. She'd had esotropia surgery. And you might hang on, you look at the heading and go, what? That's not optometry. We don't encourage suppression, we fix suppression. But I just want to show you a case where we could use a contact lens in a different way to make this patient comfortable. So she had right esotropia at 5 years, but she had this residual esotropia and hypertropia, and she had incomplete suppression, the poor thing. So some of the time she'd see double vision from this eye, some of the time she wouldn't. She was getting headaches. She felt like she had a pain, like a pulling pain around her eye. And so we tried various things with Prism to try and get the images close to each other, but she's never going to be a person who gets proper fusion and proper depth perception, because she's got incomplete suppression. And also look at the acuity in this eye. So this eye is the esotropic hypertropic eye, and it's got amblyopia as well. And we're probably not really going to fix that at age 19. So what we actually did is I said, let's try some contact lenses to encourage you to have consistent suppression, because it's much more comfortable for someone to see with one eye than 2 eyes that are fighting each other. And it's an easy thing to do with contact lenses. So I just overplus the daylights out of her to give her a chance to train her brain to pay attention to that left eye. Because the right eye is not really helping, is it? It's just making life difficult. So after a month in that, she had a really good result. She said, this feels fantastic. She felt like the right eye wasn't there, and she'd always sort of felt this pulling and pain from this eye, because obviously when it's trying to do stuff and she's trying to see with it and she's seeing diplopia, she's uncomfortable. So she actually got a really good result with that. And I've had a patient just last week who has nystagmus, and residual esotropia as well. You might remember the patient, yep. And this eye sees 6.9, this eye is 6.6, and he's quite uncomfortable and sort of switching a bit between his eyes, and that eye's not particularly useful. So we're going to try the same thing for him, just to give him about +3, +350 more than his prescription, because if it's not enough plus, he might actually want to use it for near, and just see how he feels firstly around the house with that suppression. And that can take a little bit of time to adapt to. And keep in mind also, if somebody is newly monocular, if they've just lost an eyeball, they're allowed to drive, but they're meant to not drive for 3 months until they're actually used to it. So give these patients advice that don't put this on and then go and drive. You need to try this around the house first to see how it's working. But you might think, hey, that's weird, that's the opposite of optometry. But we're in the job of making people feel comfortable, and this is a different way to use these contact lenses. Now, remember the retina. I just like this case because this patient is wearing a monovision correction because of her astigmatism. She came back with reduced distance vision, but her near vision was fine. So you go, all right, something's maybe up with that right lens. So is the right lens rotating? Is there a change in her prescription? Is the lens dry? Has she mixed the lenses up? If she mixed them up, that could be the case. And so you're thinking all of these lens things, but actually it was a choroidal neovascular membrane in that eye. So the thing to remember is that contact lens wearers have a retina. And particularly if they've, and you might go, what? But if they've had a little bit of a tricky fit and you've been thinking about their contact lenses for such a long period of time, you might accidentally end up going a year or so or two and not looking at their retina. And I just like this case because we immediately jumped to thinking this is a contact lens thing when actually it was a retinal thing. I'm happy to tell you that she's recovered 6.5 acuity after some Lucentis injections for this. So how to enjoy your contact lens practice? Be willing to try and be willing to experiment. Just act confident. Don't let patients sniff your fear and they'll know that you're, you know what you're doing. You've just got to act confident and give it a go. But make sure you explain, and I've hopefully given you some useful analogies tonight and ways to sort of simplify your clinical thinking, because patients will look for that care where you're really explaining and engaging with them. Call the lab or phone a friend if you need any help, particularly with those RGPs we were talking about before. The lab can be an enormous help for you. And don't forget BV, because it can help you troubleshoot vision and comfort problems and to help people in different ways with contact lenses you may not have thought of. Just a couple of things to stretch your brain with after graduation. You might think, hang on, my brain is stretched enough. But you're going to graduate and you're going to try and find the macula for 6 months, and then you'll go, cool, I'm good at this. What am I going to do next? So there's all sorts of things you can do. I've done 4 professional fellowships, and professional fellowships are a variation of case studies, exams, that sort of thing, to sort of prove that you have a level of expertise in a certain area. So you can do a fellowship of the British Contact Lens Association in Australia, the Cornea and Contact Lens Association, Ortho-K Society, and American Academy of Optometry Fellowship is a rite of passage for pretty much all American optometrists. For doing it as an international optometrist, it's a bit of a, I won't say it's easy, but it's a bit of an easier process. If you want to ask, then come up and ask me. But going to these conferences overseas is such a mind blower. When you go to the American Academy of Optometry conference, there's 12 tracks running at the same time. And you go, I want to see it all, but you can't see it all. So you can get some glaucoma and some contact lenses and some BV and everything. There's 8,000 people there. And the British Contact Lens Association and the NCC, which is the Netherlands Contact Lens Conference, are the biggest contact lens conferences in the world. So if you're really keen on your contact lenses, get thee to one of these conferences at some point in future to have your mind blown, to really see that blend of research and practice. Natalie's just attended her first BCLA and it was basically probably one of the professional highlights of your life, right? Yeah. So do go. And we're off to the Cornea and Contact Lens Society of Australia biennial conference this weekend. Natalie and I are off there down to Sydney. So there's some professional journals you can subscribe to, and professional journals aren't the peer-reviewed ones that you reference. They're much more clinically focused, and a couple I wanted to highlight to you, websites and newsletters as well you can subscribe to. Review of Optometry is a general optometry professional journal, and Contact Lens Spectrum is a really good one if you're interested in contact lenses. So it's not peer review, but it's all really punchy, clinically focused stuff. You can look at the stuff online, you can subscribe to the actual magazines themselves. This Contact Lens Update's a website. There's a huge amount of really interesting stuff there and little summaries of research. And these are 2 newsletters you can subscribe to, both collated by our friend Afe in the Netherlands. And there's one on rigid lenses, and you can go to the website, subscribe to the email newsletter, and one on soft lenses. So I wrote one for them recently about soft lenses for myopia control. So have a look at all of that stuff, because there's an amazing professional world of adventure to be had out there, and you won't ever stop learning. Once you graduate, you might think your brain's full. It's not full. There's more room. You just need to let that stuff settle and find the macula, and then you'll be ready to have a look at some of this stuff in future. Thanks so much for your attention, guys.